All right, welcome everybody. Thank you for joining us today for MVC Sepsis Workgroup presentation. My name is Rachel and I am one of the site engagement coordinators with MVC, and it's my pleasure to be facilitating the workgroup today. This is our agenda for today's workgroup. We're going to go through our normal housekeeping reminders and P4P credit reminders. We're going to have a presentation by Tami Garcia, titled Building and Sustaining the Michigan Medicine Sepsis Team, March 2022 to the present. Following the presentation, we'll have a little bit of a discussion, question, answer time, and then we'll close it out with some MVC upcoming events and updates. So our housekeeping items to remember, we do record our work groups. This one will be recorded today. The slides and the recording will be shared with participants following the work group via email. A reminder to please mute your microphones so that it reduces any background noise during our presentation. This helps everybody not to get distracted. And then if you have any questions throughout the presentation, feel free to put them in the chat, and we'll definitely go through the chat and make sure your questions get asked at that point in time. For our P4P participating sites, this is a reminder that we do ask you have active participation. That means answering any discussion questions that might be thrown out your way, and then also just participating. So if you have, an idea or a question, please do ask those. And then at the end of the workgroup, we will be sharing a link to the post-workgroup survey. And this is required for our P4P sites to complete to get your engagement points. But we also really love having feedback from non-P4P participating folks as well. It helps us keep our content updated and interesting for you all. All right, so today's presenter is Tami Garcia. She is the Sepsis Team Manager at Michigan Medicine. And she's been with Michigan Medicine for over 30 years. I'm sorry, has over 30 years of diverse and progressive experience as an MSN, prepared registered nurse. Her career has been grounded in critical care, rapid response, leadership, and quality improvement. She began at the bedside in the ICU, developing expertise in managing complex clinical situations and responding rapidly to patient deterioration, and later served on the rapid response team to strengthen hospital-wide safety through timely intervention. Tami went on to serve as a unit manager, building collaborative teams focused on high-quality, evidence-based care, and expanded her impact through data-driven quality initiatives to improve outcomes and patient safety. For the past 4 years, Tami has served as the Sepsis Team Manager at Michigan Medicine, advancing sepsis care across adult inpatient units, adult and pediatric emergency departments, Mott Children's Hospital, and von Voigtlander Women's Hospital. She partners closely with the sepsis coordinators and frontline staff, providing at-the-elbow support to strengthen sepsis recognition and management, and is currently co-leading development of an enterprise sepsis program to align teams under a comprehensive system-wide approach. With that, I will pass the presentation reins over to Tami for her presentation.
Hi, thanks, Rachel. Thanks for inviting me today. I'm excited to come and share kind of my team, how we became a team, why we're a team, and then some of our key things that I feel I'm proud of, milestones, so to speak, and how we got there and how we continue or plan to sustain this work together. So next slide, please. So this is my team. I have many members that I get to work with. Luckily, that my manager put us all together. I feel like we're kind of a dream team over here at Michigan Medicine. I feel very lucky to work with everybody that I'm with. I have 4 coordinators in our Michigan Medicine system that I work with. I have some physician partners along with quality analytics team. And then everyone knows Pat Poza, so I have to give a shout out to her because she truly brought me over here to Michigan Medicine and has helped develop this program with me. So why we came together, as we all know, and why we're here is that sepsis is the #1 driver of mortality. at Michigan Medicine specifically, and I think many other institutions in the country and in the world. Sepsis is really a time-sensitive medical emergency, and we don't treat it that way most times. And we're working on improving that. And when we know when we do treat our patients quickly, that we decrease our mortality, we decrease our length of stay, our morbidities with our kiddos for sure, and our overall health of our patients. So really, we came together. We have a large system here. We had variation in recognition, escalation, and treatment in all of our workflows. So it was the job of our team to come together and figure out really across these multiple units, disciplines, and transitions, how we could build a program rather than isolated fixes, because we found through our current state analysis that we had a lot of silos in our institution. So next slide, please. So really, when we came together, we had to figure out how we were going to work together as a team and really think how we were going to reach goals that we were creating for ourselves. And really, the first part of that is, why we're here. Really, we need to look at early recognition of sepsis and standardize that and make sure we have a reliable standard approach across all of our sepsis populations here at Michigan Medicine. And really to do that, we had to figure out really what was going on. We were a new program. We had many other folks that worked really hard to create a foundation for us with dashboards and beginning work with some screening processes in most of our areas, but they didn't have one team dedicated to look at all of these things together and kind of cut down those silos and make sure what we were doing was consistent across our institution. So really, a lot of our first year was really hitting the pavement, Gamba walking, going in and meeting our teams, really talking to them, working with them, and trying to figure out really what was the barrier to care, and really kind of find out what they know about sepsis and how we treat it, and do they know about best practices and how we should be treating it. What are those biases that we hold? What are we learning? And what are we teaching our new staff that are coming to our institution? And then we had to think about how we were going to sustain this. So we needed to make sure we had reviews of our cases that we could then bring back to our staff so we could learn together. And then we needed data, right? A lot of people, huge data-driven institution here. So we had to think about our data, what it meant, is it reliable, is it valid, and how we could make sure that our teams trusted it and we knew how to explain it to our teams. So really, really intentionally working to understand, really that reality at the bedside. Most of us, or all of us, came from the bedside. So as nurses, we understood fully what that means to create tools that are meaningful and not just a checkbox that we have to fill because that's something we need to do. How can we make sure that that work is better? So really looking at the reality at the bedside and then building changes with our staff and not to our staff. Next slide, please. So next we had to have a team. There's 4 of us, and that's not very big for a large institution across many disciplines. And so we had to think about who are going to be the people that could help us do this work, because really we can't do this alone. And really we needed other teams to own the work, and we really needed to know who they were, and we need to let them know why that this mattered. So we did a lot of work of the why we're here, showing them the data that we're here for them to help build sustainable tools and workflow processes so to make their work better and improve the outcomes of our patients. So really we had a core group, right? We need our bedside nurses. We need our providers, our APPs, and our physicians, residents. We need quality analytics involved so we can look at our dashboards and make sure data was reliable and accurate and able to be delivered to our frontline staff. We need nursing informatics to help with Epic, because our Epic tools are huge in what we do and our workflows to try to help guide our staff. Then we need our educators to help us, sustain and re-educate as new hires or residents are coming in through our units. We needed our ICU and our team partners, as those teams being frontline workers with us as well. And really, we had to really think about how we built the relationship with these people, how we built our credibility with these teams. And really, we did that through presence on the unit. We really made sure that if somebody brought something to us, that we responded in a timely fashion, which sometimes is hard, we know. There's so many things going on, and we really wanted to be transparent that we were learning and we were trying to make things better for the teams. And we didn't have all the answers, that we were there to kind of work with them to make sure that what we built was useful for them. So really, I think big thing from that was like building that trust, which it took time. We were a new team. I was from an outside institution, and that took some time for me to build my street cred, so to speak, and to really make sure that they understood why we were there. And really, during that time, we really prioritized listening and really closing loops of communications to build that trust. Next slide, please. So really, we had to think next, like what we were going to do, how we were going to do this, really kind of how we worked. Again, we were a new team and we were trying to figure it all out. We kind of felt like we got computers, we got some org charts to say where people might be, some units that have some high volume, some dashboards, and then they said, okay, let's go, let's do some work. So we really had to think as a team like how we were going to do that. And really the sepsis coordinators, out rounding on the units, that was our standard work that we really needed to make sure we prioritize, and we continue to struggle prioritizing as more things come onto our plate. We have to figure out how to make sure that that is our priority. We found that that is, I want to say, the biggest bang for our buck, so to speak, is having my team out on the floor and rounding with people, at giving at the elbow guidance, knowing why we're there. Because it's like whack-a-mole. If we don't keep doing this work, we know other priorities are bombarding us daily. And if we don't continue to make sepsis a priority and the care that we give, we know that it's just human nature, and our staff has so many things to do that we had to make sure that we continue to let them know why, and that we're there to help support and help guide them when they need us. So that was a huge part of our work. And we really wanted to make sure that we continue to understand all of the workflows and the other priorities that were coming their way, so that we could understand, when things don't go well, what was wrong. And is it a system issue in Epic, or was it just that was that day and there were 60 boarders in the ER and that's just what happened that day? So again, just really working with those teams. And I think another part about this that I have here is clear ownership. We're nurses. We wanted to go in and fix things because that's what we do. But we really knew that at the end of the day, if we didn't give our staff the tools or the opportunities to own this work, that's not sustainable. We can't be there all the time. And how can we empower our staff to make sure that they know what to do all the time when we're not available? Next slide, please. So really, what did we learn through all of this? We've learned a lot for sure. We've had stumbles. We've had to leave meetings where we didn't do well, where as my one, I have a mentor, Dr. Brooke Watts, and I was in a meeting and I was really being probably more forceful than I should about something I really wanted teams to do and I thought they should do, which did not go over well, by the way, and it didn't happen. But after the meeting, Brooke said, hey, can we stay on the meeting afterwards? She kind of said, hey, what the heck was that? She said, you got to remember that, in quality improvement or just at work in general with teams, that you have to create the path, right? We have to create that path so they understand why, how to do it, and that, they're on board with us. You can't drag them down the path. She goes, you literally were dragging people down the path and that didn't work. So learnings, right? Learning together. But so from that, learning that trust building is a deliverable. Like that's something that we need to make sure that we have so that we can build rapport with our staff. And when we want them to do things, that they're open to that. Really that Gemba, when we continue to Gemba, when we round, if we find a problem or we kind of see some themes in some of the risk reports, we still go out and figure out, hey, what's going on with our teams? What was going on at that time? And really go to them and ask them humbly what's going on. And really, again, making sure if somebody reaches out to us about a case or about something in Epic that they don't think is working well, that we close that loop with them, so that they know and continue to trust that we're here for them. And that the tools that we tried to create some tools that didn't work so well. And now we're have the teams on our side working with us, and they're the ones giving us the information about how we're going to build these tools together. So really together better and doing those things together. And sustainment, as you'll see in some of the milestones next that I'll show you, we're in some of our sustainment work in our adult emergency room. And that really, again, requires those teams that own that work. And we're still continue to make sure that we're there, but how can they do this work without us? We have champions, we have some standards, we have some charters, and then we continue to PDCA. As we know, things change, staff changes, conditions change. We want to make sure we're always open to that things may need to be tweaked in some certain way. And really, one of the things I remember very clearly, when reducing the burdens or alarms really is improvement, and that's not a compromise. And I'll just tell you once my coordinator, I think Rose and I, we were in a workroom trying to talk with staff, and literally this one person just said, kind of like, hey, just stop right there. Until you fix these OPAs that keep firing at me inappropriately, we don't really want to talk. So until you want to fix those for me, like kind of beat it. So it's just kind of those things that we have to really make sure that we're listening because, alarm burden is real. We all know that from being at the bedside. If we don't fix those things, like it's not good for our staff. So really just continuing to build that trust and working with our teams, which is continuous improvement all of the time. So next slide, please. So after our learnings, we started to get to work. And so when I think about the team and what we've done, super proud, by the way, of our team. I think we've done a great job together. And I pulled out some things here that I thought were kind of just key things. There's many things that we did that I could take probably all day of your time to tell you all that we've done, but these are just some key things. So really that first year of us together, we talked, as I said, we did the Gemba, right? We really learned what's going on, really rounding, hearing, listening, and really close looping with our staff, trust building. And then we had to do some team learning as well. We were bedside nurses, so then we partnered with our quality department teams and we went through advancing healthcare, which is A3s. So we really knew how to recognize, not bring solutions, but help find out what really the core problem is and then how we can fix that together with our teams. Higher reliability or organizations. How do we talk to teams? How do we build psychological safety? How do we make sure that we're humble in our inquiries, that we're not pointing a finger when we think something's really wrong and they should be doing it another way, but how do we really build that trust? And then goal setting, that was a big part of our team too. Like, how are we going to hit our targets that our leadership wants us to do and how do we get there? Because really, ultimately, our team here is here to help improve the outcomes of our patients. So for the next, for FY 23-24, we really looked at our adult ER. That's where our highest volume of sepsis patients come in, are present on admission sepsis patients. And so we really wanted to look at, they had a process that had been in place prior to COVID. And you know how COVID messed up our everything. But we wanted to bring that back together because really what we heard and a lot of our rounding is that we've lost that collaboration where, nurse might identify and then we're waiting, the provider is overdoing something else because they're busy and they're not coming together to talk about the patient. So we understood the importance of huddling, like rounding and talking about patients together and collaborating about what the nurse sees versus the provider and how they bring that information together. So we worked on that huddle process and design, and I'll talk about that a little bit more shortly. And then we really enhanced some of those Epic tools to help, again, help our frontline providers be able to do things in the moment and not have as least clicks as possible to help enhance their workflows. And then on the other side of the courtyard, as we say, we have our Mott Pediatric Hospital. We really worked on Epic tool enhancements there as well and reduction in frontline alarms. We again had alarm fatigue from our staff and they were just super frustrated with it all. So we did a lot of work there as well. In FY24, we worked with our maternal sepsis groups in our hospital, and we actually placed sepsis screening there. So all patients are now screened in our triage area and in our inpatient spaces. And we also have a NIPCO, that nurse-initiated patient care order set for our nurses. So it helps get that work process together. And then we, in FY24, we also were working in our adult inpatient hospital where we rolled out some technology after doing an A3. We found that there was Spira fluid. So we had Starling, Nikon, Baxter, non-invasive cardiac output machine that helped us figure out whether patients were fluid responsive or not. So we rolled that out in 3 of our ICUs, along with our RRT and 3 of our general care units. And then FY25, over in our NICU, our neonates, they did not have a sepsis response team or huddle. So we have that initiated to help decrease that antibiotic timing, and they're doing wonderful there. And then FY26, we are working on, or we have built a sepsis champion program for our nurses. So we're super happy about that. These nurses are at the elbow resource again when we can't be here on the unit, so that they can have peer-to-peer support for one another, disseminating information at DMS. They have boards, they do learnings with Rose and Carly. So we found that that's been really helpful as well. And with our pilot unit, we saw significant decreases in our mortality, increase in our bundle compliance with those units that had our sepsis champion. And then for FY27, we're working on our adult inpatient sepsis huddle. And I just want to put in something that I forgot here too, is one of our physician partner. He also has sepsis ambassadors for our residents and some of our physicians. So kind of pair with those sepsis champions on the nursing side to have a collaboration there as well. So really just we've taken what we've learned in our ER, and now we're trying to make sure all of the things that we have learned from that, and we're spreading that to the other areas in our hospitals. And now we're going enterprise-wide with it as well, which is kind of exciting as well. Next slide, please. So if I want to talk about, I pulled out a couple things here that I want to think about our biggest accomplishments. And what we're trying to sustain right now is that ER workflow. And this is our first iteration, and we probably have 3 of them now. So this is not exactly what we're doing, but I just wanted to put it up here just to kind of show you. This is our sepsis huddle, where we worked on getting our teams together to talk. So as soon as we have our patients screened and it is positive and we have some organ dysfunction, then we have our team coming together to talk about the patient and say, okay, we have these things going on. Is it sepsis? Yes or no? And then if it is yes, then we have things that they can order quickly with some bundle banners and some instant orders in their navigator to help kind of just speed that process along. And it's been really, really successful. And I'll show you some data next with our team. But I think I just want to point out that we have a code sepsis on here. And that's where we paged overhead and said, hey, we have a code sepsis in Bay 12 or whatever. I'm kind of making those numbers up. But quickly, we had literally people knocking on our door saying, you have to stop. This is causing chaos. It's more noise. We don't know where to go. People don't know what to do. So we quickly turned that off. And that was one of our first, okay, aha moments. We got to work more closely with our teams and make sure what we roll out. And since then, we do have some push notifications, and that's working better. We had pagers, and now we're into our push notifications with our phones because pagers finally went away. So just kind of learning those processes with our teams. And really, this has really been supported, and it really has shown us how we can rapidly align our teams with clear roles that they have, really to escalate the care that needs to be given and make sure that with that time-sensitive nature of it is done quickly. And we've really continued to enhance our Epic tools. They're not perfect. They never will be. Because I think we also found that, we can create as many tools as we want, but it's the people on the other end making those clinical decisions and using them in really, busy moments, hectic times that is really the success of that. So again, just listening to them. Next slide, please. So this just shows after our huddle, we look at SEP1 or CMS bundle of care, sepsis bundle of care. I think most people are probably familiar. If not, I can talk to you about that for another hour as well. But really, if you can see here, this is our FY26 data, and this is our ER alone, our adult emergency room. And you can see clearly that, our bundle compliance for FY26 has been amazing. I'm super excited. I don't have March on here. We were 90.9% again in our ER. So that's putting us at 80.6% bundle compliance for FY26, which is our all-time high. So super proud of that and our teams. But the graph on the right here, you can see since FY22, when we formed as a team, you can see that our bundle compliance has come up from, this 50% up to like 80%. So again, super proud. But then if you want to look at the numbers on the bottom, the graph, this is representing the mortality decrease in our patients, which again is, why we're here, why we think this work is so important. And it really correlates with, increase in our bundle of care, and getting that done timely really does help improve the outcomes of our patients. So super proud of that work and our teams. It's not me, it's them at the bedside. So super proud of them. Next slide, please. So next, I wanted to just point out another one of our sustained accomplishments, but I think we're kind of pre-sustained, but we're still trying to standardize this, especially as we're rolling it out to some other areas right now. Our ICUs are where we started that. Again, you can see here that this is where we did our initial work with our teams to try to get some buy-in. ICU folks can be hard. I came from there, so I can say that. They were really fluid compliance continues to be our highest mode of non-compliance here at Michigan Medicine. And so we wanted to find out why won't we give these fluids? My previous, someone that I had worked with previous said, we were very hydrophobic here at Michigan Medicine. And I would agree, we are. It's just really hard. And so we tried to get to the bottom of that. So we really did the A3, the fishbone, gap analysis, as you can see here. And then we found out that it was fear of harm of our patients. We don't want to give too many fluids and have them intubated, or, if they have a heart condition or heart failure or anything, they didn't want to harm our patients. So we we did some research with some different technologies. And so we wanted to find out what can we do to help our clinicians make in the moment decisions about the care that they're going to give to their patients. So NICOM, Starling, Baxter's what we landed on with our teams. Again, we let them decide. We brought the technology to them and said, hey, which one do you guys like, or do you all like better? And which one should we start to bring towards our team? So we started with that technology, like I said, in 3 of our ICUs with our higher volumes of sepsis patients, with our medical intensive care unit being our highest volume unit. And then we've slowly expanded it now to our rapid response team, who now, if they have hypotensive calls and it's rapid response, then we have the machines and monitors on 3 of our general care units where they can bring those to the call, and then they can use that in the moment to help if they want to guide fluids with these patients if they have questions about it. So we really are working on, again, standardizing that. We have, sorry, can we go to the next slide, please? So really how we did this work and how we're continuing to try to standardize this is we have a lot of training, and Baxter works very closely with us, and Rose and Carly do a great job of, educating our teams in the moment and when they need help. We have wonderful staff helping us with that. Standardizing the workflow, we're still in that process of like trying to make this really a part of that standard. And I'll talk a little bit more about our sepsis huddle and how our inpatient stays trying to like standardize it through that approach as well. So we're still working that, but we have an algorithm for our teams to follow. We have order sets, we have notes, we have dot phrases available for them. Again, just kind of continually have to teach in the moment about that. And we keep thinking about how we can continue to give them and provide them ongoing support, troubleshooting, reinforcing with them, and then bringing data back to them as well, which we know is really important for them as well. Next slide, please. So this next slide, I just want to show, all of the work that we're doing. Again, I feel like this is one of my proud slides too, right? If you think about our team forming in FY25, these are severe sepsis and septic shock cases in our adult hospital, including the adult emergency room. And Rose brought up a good point. I didn't put an end here. I didn't have time to go back and look, but I think it's about 1,200 patients for these 4 years. But you can see our mortality rates from 26.2% down to 20.1%. So again, we have some work to do still, but still we're making some good progress. And it really makes me happy that I know that some people are going home to their loved ones So that's why we're here, and I want to continue to do this work. Next slide. And then I just have a couple other additional milestones. If you want to go to the next slide for me. Because I want to think about other hospitals that I work in. So over in Voigtlander, our maternal sepsis screening, we have universal screening, as I had said before. We now have screening in our triage area and our inpatient area. Along with that, nurse-initiated patient care order set, the NIPCO. Our screening rates, they really have knocked it out of the park. This has been a team that really, from the get, their leadership has embraced this work with us and really gone full force with it. You can see their screening rate in their OB triage is at 91.6%, and their inpatient area is 78.7%. And this just came live in May of 25. So I feel like that's pretty great progress in one year for them to go from zero to this. So kudos to those teams. But again, we can see here our sepsis bundle compliance has also gone from when our team formed in 22 from 27.3 up to 55.5%. So again, just really good outcomes that we're doing some great work with those teams and for our patients there. Next slide. So when I look at our pediatric hospital, I kind of alluded to this before, but we had epic tools that were alarming. We had some vital signs that were going in from our respiratory therapists, and we had viral seasons that were really kicking this OPA into overdrive, so to speak. And so we did some tweaking, working with our HITS people, listening to our team, Sarah out there rounding with them and talking with them about what was bothering them most and really disturbing the work that they needed to do, besides answering this OPA that was firing inappropriately. So when we did that, you can see here that in June to December of 22, there was about 35,000 alarms that went out to our staff, or alerts, I should say. And she ran another report from June to December, and we're down to a little less than, it looks like about probably 18,000 alarms. So really reduce those quite significantly for those teams. And when we're rounding with those teams, they feel like they notice that as well, which I think is huge, because sometimes we make changes and we can see data, but is it really affecting the staff? And they are noticing that. So we're continuing to tweak that with those teams. So again, another one of those things where, listening to your staff, how can we make things better for the teams that are really doing the work? And we know alarm fatigue is real. Next slide, please. So when we look at our NICU, our neonatal intensive care unit, I had alluded to a sepsis respond that they have put into place that started in December of 25. And Kate Wilson, she's our physician partner over there. She had done a lot of work on increasing this order set use and to help decrease the antibiotic timing. And you can see in this slide here, the blue areas getting bigger, right? That's under 60 minutes that we want to get those antibiotics into our tiniest of little victors over here. So you can see that all the work that's going on there, and you can see our order set use, this dotted line at the top, that's the 100% mark where we want to be. So we can again show that, using those order sets really are helping the outcomes and the care of the kids that are being taken care of over there. We don't have a lot of data yet with our SRT, our sepsis response team at this point in time, but I hope to have more soon to kind of show how that's going to help with our outcomes as well. Next slide, please. And then just one last thing I want to kind of just talk about is our adult hospital RN sepsis champion program. Rose has been pivotal, and we have a nurse here. She's from our unit that we piloted on in 8C with a leadership team there, Brandon and Latoya, great team that came together, and they said, hey, we want to do this. We see a lot of sepsis patients. How can we do better? How can we help? So this is where the program started. So I'm going to give a shout out to them and those teams. The data that has come from this, like I said before, we have increased bundle compliance, and that we have associated decreased mortality with these teams. And this is one of our higher volume units in the hospital. So super proud of that, really building that program. So we have some local reliability, reinforcements of those workflows, and really roles or role models for their peer-to-peer, other nurses on the floor, the new nurses coming on, people are getting floated there that they can help each other out. So they've done a really wonderful job there of doing that. So we're super proud that we've spread this across most of our units now. I think we have about, gosh, I'm going to massacre. I think we have at least 30 to 50 nurses now on this team that are doing this work, meeting with us regularly and spreading this information to our team. So I'm super excited to have them all on our side working with us. Next slide, please. So really next steps, what are we going to do? We got to continue all of this work. It's a lot. Um, we have to continue to make sure that our ER, our adult ERs and our children's ERs, where we see the most of our patients, that we continue to sustain this work, make sure Epic still works reliable. We are moving to one Epic, which is really scary to me. So we got to figure that all out. I think we're probably a lot of us are in those boats together. We have the provider sepsis ambassadors that I'm really excited about, that we have to think about how we're going to utilize those teams and bring the nurses and the providers together. We're going to continue to maintain and spread our NICOM use in all of our areas and make sure we're monitoring how that's adding value to the care that we're giving. And in our children's ER, we are looking at the huddle in that area, our sepsis huddle or SRT. It's been in place for quite a while, so we just want to make sure it's working like it's supposed to be, that it's really affecting our outcomes and make sure that it's the best thing for our team at this time, and, kind of that juice for squeeze, so to speak, and make sure it's doing what it's supposed to be doing. And then we're going to continue to think about how our maternal peds and NICU, they continue to function again, to kind of sustain that work and continue to make sure we're making traction there, and then strengthen our champion support and onboarding, because that's a constant thing. I know Rose is like, oh, I have 3 more people that I got it. It's a good problem to have, but it's also work catching people up. And so we got to make sure we continue to do that well and make sure we're supporting those teams the way that we should be. Then next. So to close, really, what did we build? We really have this multidisciplinary team that really we've built it through standardizing our work, creating trust, and really making sure we have really good tools there for our teams. And then we're going to have to sustain. We got to sustain these huddles. We got to make sure that people are still coming together all the time, whether it's sepsis or not. We have a deteriorating patient, and what are we going to do quickly so they don't? Hopefully, we decrease the use of the ICUs by stopping the process of deterioration. Continue our NICOM rollout and our sepsis champions along with our sepsis ambassadors. And really, we want to continue to pair or partner with our teams and make sure they understand why we're here, that they trust we're here for the best of everybody, them and their patients that are involved. And then we make sure that we have the best outcomes for our patients when it comes to sepsis care here at Michigan Medicine. And that's all.
All right. Thank you so much, Tami. That was a really great presentation. We are going to move into our discussion and question time. So if folks have questions, feel free to put them in the chat, or you can raise your hand and I will try and see if I can see you. All right. See. I don't see any hands yet. All right. So I did I did have a comment from Tami Gallagher kind of earlier in your presentation. So I'll just say that one. She says, Tami, I appreciate you calling out the need to build trust. I don't think this is often highlighted in quality improvement, but it is just as important as the actual intervention in implementation success. So that everybody gave a lot of hearts and thumbs up for that one.
I know, and I do see the question about how did you gain buy-in for the huddle and the ER. Peter England, he is one of our partners. He was just working with our adult emergency room when we first started this process, and he was here for the original huddle that we rolled out. So I think, and he has been I'll say a sepsis influencer for a while down in that department. So I feel like he was huge in that part. And we also had Renee Havey there. She's the CNS, and she's also was involved with early on with sepsis initiatives and the initial sepsis huddle. And I think they had a pretty smooth process before we got there. So I have to give them a lot of credit for that. But I really think that after we reintroduced the huddles, we did hear grumbles, of course, right? Because they thought it would increase the work. They have to go do something. But really, in the end, it helped that care. They didn't then have a deteriorating patient they had to move to EC3 or into the recess bay. So I think that they saw through the work that it actually improved the work and care that they were giving to our patients. And I think that Carly also, her presence down there and trying to show them the tools in the moment as much as she could to show again, this is how it works. This is how we're trying to make your workflow the less clicks as possible, having it all there for you. So I think it was just kind of a culmination of all those things together that helped us with the buy-in. I mean, we fair amount of people that were not happy, but they did it when they found out that it was actually a better process and improved the outcomes for our patients. And the celebrations, we really did celebrate with them. With the ER leadership was really great with us when we had some of our highest SUP 1 bundle compliance numbers coming in. You know, those teams helps the leadership down there really helped us support us to celebrate them as well. And I think that's important as well is that we show them the great work that they're doing.
Wonderful. Um, Chris says, love the idea of sepsis champions to achieve buy-in. Laura asks, have you thought about incorporating any of the new
Mm.
tests for sepsis, IntelliSep, Traverity, etc.?
Yeah, you know, we have explored a couple of those. We're working with our lab, and we hadn't found any that we thought we could work with yet. I think Traverity just reached out to us again, and I believe that's one of them that is now FDA approved. So long story short, no. What we have looked, but we haven't done anything serious at this point in time yet. But could be future. I'm not sure yet.
All right.
Um,
Go ahead.
Oh yeah. No, I say yes. Yeah, that's a good question. We actually have we had our quality and analytics team also about the documentation of the huddle. Yes, we have found that difficult. We first had it just provider and it wasn't happening, and then we had the nurse and then it started to happen, but then our CMS abstractor said, no, it can't be documented by a nurse. It has to be documented by a physician for it to be a negative to not count towards it being called sepsis. So now we're actually tracking that. We have in our dashboard so we can see who's documenting, who is not documented in a timely fashion. And then we just started a feedback process about, I want to say it's been 3 or 4 months that we started a feedback process where when we find where somebody didn't document that, we're just saying, hey, you know, here's your sepsis case. Here's what's going on. You know, we see that where you weren't able to, can you help us understand, you know, how we can make this better? So we are looking at that, but yes, challenging. So I don't have a real answer yet of how to solve that yet. We're hoping this feedback process will help us.
Awesome. Do you want me to read the question out loud for you?
Sure, go ahead.
Okay, all right. So Abby is asking, or says, amazing to have such a robust RN sepsis champion group. How
Mm.
frequently do you meet with your RN sepsis champions? How do you keep them updated on sepsis committee work QI project goals?
Okay, I can answer this. Or Rose, I think Rose Mulcahy's on too, and she can help me. But yes, Carly and Rose meet with the sepsis champions monthly, and they dispel a lot of information within those meetings. But we also have a great admin who has helped us build out a sepsis or a SharePoint site that we have all of our information there for them as a reference. Anything else, Rose, that you can think of?
No, you summed it up nicely. But yeah, every single meeting I'll have, whatever's going on in the hospital. The expectation of the champions is to then bring back the information that I shared at the meeting to disseminate to their teams, because it is a large institution and difficult to be every place. And then the champions will share barriers with me, case studies, things that they want me to discuss at the future meetings. So it's a touch point to hear what is going on in each of the units at the individual level. And then I'll have them also share information that is going on in their departments so that way other units can learn from the improvement efforts that are going on.
Awesome, thank you. Christine has a question. She said, from what you said, there are 4 of you that work only on sepsis. Do you divide the work by service line, one for peds, one for ICU, one for ED, etc.?
Yes, I can answer that. Yes, there are 4 of us. Myself as the manager, I help support all areas. But Rose, who just was on the call, she is primarily in our adult inpatient space. Carly, that I referenced, she is primarily ER, but she also now works in our inpatient spaces. So we're finding that to be a big, we call it the beast there, because there's a lot of service lines, a lot of units that we're trying to tackle and handle. And then Sarah, our another coordinator, she works over in Mott and Von Voigtlander. So she has the women's, the adult or the children's ER, the pediatric units, and then the NICU, our neonatal intensive care unit.
Wonderful. Jennifer asks, how do you track performance? Can you explain how or what your coordinators review to track their track performance?
So I guess when you think we're thinking about performance of sepsis, the bundle compliance, is that what we're thinking? Because we do track, we look at these numbers. We have a couple different dashboards, and we report those numbers out monthly with most of our teams. Sometimes it's or like quarterly with our teams. And so we look at our bundle compliance, we look at our mortality, we look at our overall length of stay, and we look at our ICU lengths of stay is what we look at mostly, just kind of see about what the outcomes of our patient.
Okay, great. Andrew asks, have you seen a lot of improvement in inpatient ICU, non-ICU sepsis cases that pass CMS specifications? And then what did you find was the biggest catalyst for improving inpatient performance?
So on the adult ICU numbers, with our CMS cases, we have seen an increase in our inpatient sepsis numbers alone. So yes, we are doing better there. We haven't dove into a lot of those cases, but yes, that is helping. And then the other question was, what was the biggest catalyst in the inpatient area?
Yes.
Is that what the question was? So this is my rendition. Wait, we have many service lines here at Michigan Medicine. Nurses are in units, and that makes it we're nurses, so I feel like that makes it a little bit easier for us to get to those teams and talk with our nurses. Getting to our APPs and our providers has been a little bit harder. I do have to say that we now, in the last probably year, we are hiring an inpatient provider to help us do the work in the adult area, and bridging that gap between providers and nurses and having more providers work with us, that has really helped bridge that. So provider engagement has been hard. And I think that's not just in Michigan Medicine. I'm not saying that, but I think that's been our biggest gap and our biggest catalyst. But we are closing that gap as we are supplying data, having them validate data with us, and then having our physician partners help us with this. That's really helped us a lot.
Wonderful. Carol is wondering if you can share the fluid algorithm with the group. She sees the fear of harm often with their teams.
Yes, we absolutely could do that. Here, do you want me to? I can just give it to you, Rachel, and we can share it, or it's in the slides too.
Yeah, that you can send it to me, and then I'll put it in an email.
Okay.
If it's not like visible, super visible in the slides.
Okay.
All right. Jennifer wants to know, what is the bed number your team covers? How many ED visits are you seeing? Interested about the workflow and workload of the coordinators.
I believe, I don't know the exact count of beds. I want to say it's like 1,200, Rose. Is that about right? Amongst all of our hospitals, all of the beds we have here. And so if we're thinking about adult ER visits, we see about 175 to 200 cases of sepsis in our adult ER. And we see in our children's ER, it's between, I think it's like 100 to 125 cases a month in those that unit.
All right. The question from Julia is about the SEP1 bundle abstraction. Are you using the new sidebar tool available in Epic for the abstraction?
No, we started to explore that. And to be honest, we didn't think it would be helpful. We actually had our abstractor meet with us as well, with our HITS person who had gone to the Epic foundations and learned about it. But I think that we need to explore it more in the future because I feel like it hadn't come to us yet. I think with the newest update, it was supposed to be available to us. So I think we want to look at it. So we haven't. So if anybody has used it and it's helpful, I would love to know how you're using it and how we could possibly use it to make, abstraction more cases that we could see, the better for sure.
Okay. Let's see. Where was I? Do you get a response when you send feedback to your team members?
We do. I think it's taken us a while to get there. And Rose can probably speak that to a little more. I think kudos, if we're giving a kudos, I don't think we hear back, but I think now that we have stronger physician support, that more of our physicians are now, our providers are responding back when we have some fallouts to talk about the case. And I don't know if it's just because, our providers are there, or there's increased awareness of sepsis in the work that we do.
All right. And then Jessica wants to know, how often do the nurses in the ED get education um, to help recognize early signs of sepsis?
Carly does all the new hires. So she sees them. And then she is at their UBC every month talking with staff and giving updates and educating. We also have a cornerstone that the nurses have to do upon hire. Um, and that's kind of our cadence now is it's just those regular touch bases every month, kind of seeing where the gaps, getting to the new people. And when we have new technology or new tools, then we educate to that in the moment. But we don't have any yearly mandatories at this time for any of the staff.
All right. And then it looks like we have one more question from Amy. Do your feedback request response from the team, or do they provide it on their own? I don't know if that's clear.
Let's see. Yeah, I don't know. Amy, could you expand on that a little bit? Does it
Does it
ask
ask?
for a response? I believe it does. Rose, what does it say? But I think so.
Wait, I'm sorry, I missed that. I was putting something in the chat.
No, it's just saying, do we ask for on the feedback form, do we ask for them to respond to us? I think we do, right?
Oh, in the feedback form, I'll put, if you have any questions or feedback, but I have been getting a lot of responses I make it a very much a humble inquiry. How are, great care on something. However, here's some tips how you could do it better. And I've actually gotten really great engagement with that approach. And so I've even had physicians writing me back and forth, how's the documentation look now? And, um, nurses, oh, I'll, do this better next time. So I've been getting a lot more responses with that approach. And then I'll even add in like, here's a couple tip sheets, how you could document better or, things for next time.
All right. Wonderful. Thanks, Rose. All right. It looks like our chat has quieted down. I'm going to double check I don't have any hands raised. And then I think we are at time, so we're going to move on to our MVC updates. Again, thank you so much, Tami. Thank you, Rose, for joining us. That presentation was really informative, and I really hope everybody took away something from it. I feel like it had a little bit of everything, so we really appreciate it.
Well, thanks for having us. Any questions, please reach out. Our email is on the slides there. If you
All
guys
right.
want to connect with us, please do. We love to collaborate.
Wonderful. All right, so I'm going to move us on over to our upcoming work groups. We have our next one on Tuesday, June 9th. This will be a MyCR and MVC collaboration. It's an ICR virtual forum, and it's going to be on telehealth for cardiac rehabilitation. There's going to be some fun live I don't know if I should say acting, but some fun interactive things to do during that one. So I encourage you to join. And then on Thursday, June 25th, we will have a health and action work group. This is going to be focused on AI-enabled clinician feedback as a quality improvement infrastructure. And a reminder that all work groups are virtual and they are from 12 p.m. to 1 p.m. Some of our upcoming events, we have our MVC in-person networking event that is going to be Wednesday, June 17th from 4 p.m. to 6:30 p.m. We are going to be at Luna Restaurant in Grand Rapids, Michigan. Going to go to the west side, and registration is open until June 9th for that. I will be sending the link for that registration in the email, and it is also on our website. And then just a little heads up, we will be sending out our annual QI survey to site coordinators in the beginning of June. So keep your eyes open for that. And then always, as always, calling for presenters. We always love to have our members present at our work groups or at our collaborative wide meetings. So we have several work groups still within this year coming up that we'd love to have folks present at. You can see the calendar on our website to see which ones are coming up. And then our fall collaborative wide meeting, where we're going to be looking for presenters for breakout, podium, all of the above. So feel free to send in presentation proposals if you have a QI project or system-wide project that you want to share with everybody. And that is it. I believe Emily already put the post survey link in the chat. It will also go in the email that I send out later today. Everyone have a great rest of the day.